13th of June 2025, 6:30 p.m. Content.
Perhaps we can replace the chair with AI.
What have you members?
Good evening and welcome to this meeting of the Adult Social Care of Select Committee. I am Councillor Lucy Knight, Chair of the committee, and I will be chairing tonight's meeting. This event will be streamed live on YouTube, and members of the public and media are welcome to watch the meeting remotely and listen to discussions taking place. Now I'd like to welcome you all to Committee Room 1 at Committee Town Hall and everyone watching on YouTube. Before we proceed with this meeting, I would ask everyone present to please make sure your mobile phones or laptops are on silent or switched off, and we will start with 72 seconds silence to remember those who lost their lives in the Grenfell tragedy. Agenda item 1 is apologies of absence. We've had apologies tonight from our councillors Gerard Hargreaves and Stephanie Petit. Anyone else?
Yeah, we have also had apologies from our health representative as well.
Agenda item 2 is declarations of interest. Does any member have an interest? And then agenda item 3 is the minutes held from the 29th of April and 21st of May, which have been submitted for confirmation. Does the committee agree that they can be signed as the correct record?
Agreed.
Great. And then moving on to our first paper, which is our agenda item 4, dentistry and oral health. The purpose of this report is to summarise the prevention and early intervention measures in place to address oral health in children and adults in the borough. Pleased to welcome our guests from the local dentistry committee, NHS and ICP meeting, in addition to local councillors and our lead member Josh. Thank you all for coming. Now can I please invite our guests to briefly introduce themselves? I'll let you come up to the table first. We have Councillor Josh Randall, Anna Raleigh, our Director of Public Health, Marina Koya, who is RBKC Change Development Programme Manager, Dr. Zara, Local Dentistry Committee, and our Borough Director, Council name wrong, Manaya. We've got Manaya. Who is Clinical Director, Community and Specialist Dental Services.
Oh, that's mine.
So apologies from Marina, who's unwell.
Okay. We've got Kelly. Yes, Kelly Davis. Our regional lead.
Which one? Oh, on the other side.
Yeah.
Sorry, guys.
That's right. A bit just done on July.
I'll let you come to the table and then introduce yourself and whoever is the lead.
Yes, Lake, Deputy Director of Public Health.
Kelly Nisser, originally for dentistry and family services London.
Jeremy Moore, Head of Primary Care Commissioning, Dental, Optom and Pharmacy for the London region.
Judgment Doctor November.
And Raleigh, Director of Public Health.
And if I very briefly introduce
the item. Just to recognise the importance of the topic, that there are significant numbers of young children who experience tooth decay, and this is very much an agenda where partnership working is really important, as reflected in the representatives that you have at the committee this evening. So this is one of those topics where public health and local authority is particularly involved in relation to promoting oral health. We've summarised the work here in terms of what we do with young people and also the care homes. So that's been a particular area of some developments in recent years. And then we've also identified some of the challenges in relation to dental provision, which are experienced locally and indeed in other parts of central London, and identified the inequalities that we're very aware of in terms of those groups that tend to have poorer oral health outcomes, which we can identify by deprivation, but also in terms of some relationship to particular conditions and lifestyle risk factors. So we often use childhood obesity, for example, as our proxy for identifying oral health. We have a national child measurement program which gives us a picture of childhood obesity right the way across our schools. We don't have that kind of level of data when it comes to oral health, and other groups such as our homeless population and rusty. If colleagues want to make any opening notes, I'm sorry if we're happy to take questions.
Yeah, happy to take questions. I mean, from a commission point of view, as has been mentioned, obviously there's a level of collaboration that goes on, particularly around the oral health promotion space, because the community dental service that we commission, and certainly specifically in North West London, will also be the provider of oral health promotion as commissioned by the local authority as well. So it's the same service, but you'll have oral health promoters working within the community dental service. And obviously that outreach work is really important, obviously in terms of just the basic level of education around good oral health. But it's not something, I think it's one of those, it's just a continual struggle, I would say, but it is challenging in terms of getting those messages out, because obviously access to dentistry is varied, to say the least. But I think on top of that, regardless of whether people go to the dentist or not, some of that just oral health advice is really, really important, because it's just that whole thing around it. It's as basic as being able to give a level of instruction around children brushing their teeth with great regularity and all of the diet advice that goes with that, which is really important. You get a level of that when you go to the dentist, but not to the same extent. And because of the way the NHS contract works, there isn't really a huge amount of oral health promotion, which is sort of tangible within the contract that is provided by dentists. And I think on here, and we obviously take questions, there's a whole slide deck on there, which is a bit of a dump really in terms of just the level of detail, which, you know, maybe people are familiar with and maybe they're not, but it sort of hopefully gives people a little bit of context in terms of the numbers and the sorts of investment that there is there in terms of the dental practices and just dental services generally, but also just to give it some context that actually, as challenging as it can be, London actually fares better than anywhere else in the country. In terms, I'm not saying it's perfect by any stretch of the imagination, but I think it's important to get across that actually levels of the availability of NHS dentistry is high compared to other parts of the country, and also the delivery against those contracts is exceptionally high. Obviously, we've got a massive population, and obviously many parts of London, deprived population as well, where NHS dentistry is the only option for many people. But in some cases, even that is a problem, because obviously there are NHS charges that are levied, which have to be levied. And if you're not on certain benefits, you have to pay them. And that is prohibitive in some cases to patients accessing NHS dentistry, because it's irrelevant that you can compare NHS dentistry charges with private charges. If you don't have that money, you don't have it. And so that is a continual issue, which we recognise, but it requires a massive change of legislation. ICBs now in their iteration are not in a position where they can arbitrarily change that. It's a bit like prescription charges. They are effectively mandated at a national level, and those who enter into contract, particularly NHS dentistry, have to enforce those fee structures. But we recognise it's a real issue for many patients.
Do you want me to say, Jen? I mean, I can get rid of this as well. But yeah, I can see our report. Advocacy obviously still has really a lot of challenges, especially for those under 5. To duplicate. Of course, we're here now, obviously, to obviously hear your advice and views on that. We do run certain programs, the public health team run, and or Jack here do that as well, especially Keep Smiling program. We've had a really successful launch in Colville Primary School recently. We did a little video on that. We had some people come in to teach students, how to brush their teeth, how to do oral hygiene, of course. But also we work with other schools like Queensmill, which is our learning disabilities, a special SEND school that we have that kind of availability as well. It's interesting that you still have this challenge, because when I went to A&E at Chelsea and Westminster Hospital on a tour, I know the committee has done so separately. One of the things that the A&E doctors and nurses have said that a lot of their cases they see, and not consistency, is children with duty care under 5, and that's a real big thing for them. Not so big a range of people coming with all manner of health challenges that they may have, but this was one of the things that they said that kind of percolated in their mind, because it was enough of a concern to say this is a consistent message that I'm seeing across the borough or wider at the hospital have to serve as well. So obviously there are still challenges out there that we need to address. And the figures are in here. I mean, with 23%, that's, it was saying probably too lower than England, but still quite high for in general. So I mean, that's something we're very, very aware of, and Adam and Jeff have some good ideas on how to tackle it from a public health perspective. But obviously, there's more to do.
Thank you very much. Thank you so much for the report and also for that update from all of you. I'll see if anyone wants to start with questions.
I had some questions about the research that you mentioned in the report. You said you got some feedback, and you talk here about the themes and some of the things that people said. Can you tell us more about that research?
I don't think that was me. I think that may have come from our colleagues.
Which paragraphs?
So in the 8.10, NHS London gathered dentistry feedback covering the period October 22 to 23, and it talks about some things. I mean, maybe you can talk about the things.
Yeah, sure. Yeah.
It's
Absolutely.
struggles reported in registering with NHS dentists, issues related to updating patients on dental practices. So, I mean, I guess,
yeah, sure. Yeah, absolutely. Touch on that. I mean, I think I suppose the biggest difficulty that exists around is the terminology registration. So registration with an NHS dentist formally ceased on the 1st of April 2006. So there is no such thing as registration with an NHS dentist. I know that people will perceive that they are registered with practice, particularly if they go back regularly, but that formal link doesn't exist. So when people say, I want to register, the obligation, if you like, if a dentist agrees to take someone on, is for a course of treatment. The obligation ceases once that course of treatment is finished, and that may be just a checkup. So there is no obligation on the dentist to see you again. Vice versa, there is an obligation for the patient to return either, because that's how it worked previously. So I think one of the factors is obviously they have a contract where they have to deliver a certain level of activity. So if you think about it in a wider sense, as long as they deliver their activity as per their contract, they don't have to see the same patients routinely. Now, a lot of people do, but I think because of the way capacity is, they can be maybe a bit selective about who they see. And that is just the reality, unfortunately, and they can do that. But I think it's certainly in terms of updating, it's a contractual requirement now for practices to update their status on NHS choices. So that it's very, very clear in the status of their acceptance, so their status of acceptance. So whether they are accepting everybody, adults, children, exempt adults, or otherwise they have to update it. Now, the only issue with that is quite often their status can change by the day. So it could be up and down quite considerably, but they are required to make sure that that profile is updated regularly, so that anyone wanting to find a dentist, if they shouldn't be bringing them up and saying, yes, oh no, sorry, we're not taking, well, that's not what it says on the website. So there is a real requirement for them to do that periodically. They are prodded by us to make sure they do it. It is difficult to police, I'll be really honest, because we've got 1,500 dental practices across London, but it is a contractual requirement, and it can extend to them being breached contractually if they don't do it.
And how often does that happen?
Not very often, because actually in most cases they are reminded regularly, and in the main they do it. They do it, but I'll be really honest. If some people might say, well, actually, we didn't do it this week, it's updated next week. It's not something that they necessarily do on a daily basis. But I think because of the capacity issues that exist, they could well be doing it every day. So it'd be open one day and close the next.
And I had another question as well, which was about the support that these dentists get. So, for example, I mean, I've been talking with a dentist who wants to open a branch on High Street, Kensington. So I know a little bit about this and the pressures that he faces. Obviously, there's a contract where they are, paid whatever you've outlined in the paper that they get for the checkup and the treatment performance and the kind of tier 3 treatment. But if you're somebody like this dentist and you're setting up a new practice and you're not getting any help with the rents or the staff fees, or there's a lot, there's a contract, but they're not getting help with the running costs. How does someone like that actually open?
With great difficulty.
Right.
Is the honest answer. So the way it works now, prior to 2006, you could have just set up and assumed a contract. Contracts then were directly for the Secretary of State. Once we moved into the contractual arrangements we have now, it's for a fixed sum. A bit like GPs in that respect, but the difference with GPs is that within the money that we pay dentists to deliver NHS services, there are no reimbursements for rent or staff. The money is purely for dental treatment, and again, that's part of what you would call the statement of financial entitlement. So what they're entitled to, and in terms of contract, that will only come about if now the ICB decides they need more dental coverage in that area, and they have the money to issue that contract. And I think you probably all know this, the parlor state of NHS finances at the moment is that it's unlikely that they would, and effectively it would go out to tender. So it'd be a competitive procurement. So there would be no guarantee that dentist would win.
I'll just add something to that. So I think it's worth noting that during COVID, there were some terminations of contracts where dentists had decided they weren't going to continue or weren't going to continue into the NHS. And therefore, in the areas where that happened, we went back to the ICBs to inform them, and those funds were either dispersed back within the NHS practice locally, or looked at if they wanted to do anything different. So we as a team have always gone back with anything like that's happened. Also, if there's any funding that's available where there's underperformance, so as Jeremy talked about, your contract is for a certain amount of units of activity. If you don't see that number, then you'll have the clawback. And when that clawback happens, we'll take that money and say, actually, do you want to use this year? And we've been actively doing that over the last couple of years that we've been into the ICBs. And North West London has been putting in funds back into that pot. It's worth saying you could go out and offer that money to all our practices, and you may not have very many that come back and say, actually, we want to do that, depending on the borough you're in. So depending on what part of London you're in, as Jeremy said, you've got the deprived parts where they'll take the money, but actually it gets followed up in a couple of months. And you could use it in borough like this, and I've been working in North West London for previous to ICB world, so since 2006, and a bit versed on Kensington and Chelsea. So I remember that even when we've opened up, so the Earls Court practice, you know, when those have opened, we've had issues where we haven't had patients attending. So they've had a shortage of patients, and we've had to, it's been about raising awareness more. And the other thing to say is sometimes when you are told that, and depending on what area, I'd be very careful with what I'm saying, but this with knowledge, I can say what I'm about to say. Depending on what borough you're talking about, it's about the snapshot of when you've talked about, are they able to see NHS patients? Because Kensington and Chelsea, in my opinion, is not at the 32 boroughs, one of the ones I would worry about access to an NHS dentist and capacity. You have sufficient practices, and even on the needs assessment, it is one on the lower end of the whole of North West London where you don't have NHS dentists. So April is when the new funding comes along. Obviously, financial year's ended end of March, 1st of April. It's probably the time when you're going to be able to see an NHS dentist, probably in a couple of weeks. And if I compare that to, say, Newham, for instance, which I know we're not talking about, but just giving a comparison, you could be waiting 3 months before you see an NHS dentist, and even then, they've already got waiting lists from last year. So you are in a better position. And it doesn't change a lot, but it's just thinking about when that snapshot was taken, because that could be at the end of last financial year when practices may have a smaller contract. It's also worth just saying that in Kensington and Chelsea, you do have practices that have part private and part NHS practices, because it's the area you probably would get patients who are able to pay for that. So you're going to have a mixed bag as far as practices are concerned in Kensington.
So it feels like really if you're saying there's a shortage of, that seems completely, I can't even believe that Earls Court has a shortage of patients. So to me, that suggests that people just don't know where to look.
It's the awareness, yeah.
And they don't know how to find the dentist, because I just can't believe that.
Yeah, and that goes back to the website, as Jeremy says, the NHS choices and looking for an NHS dentist. I think from an ICB perspective, there's been a lot of work, and that's something that we're trying to work with them in regards to how to do that. We've got an urgent care service, again, if a patient needs a dentist out of hours, and that's across all of London. Everybody has the same service where you dial 111 and you'll go through to a service. Again, even through that service, they will recommend, if you go on NHS choices, you do get hundreds of thousands of patients going through that service that are actually directed to the website. Outside of that, again, obviously, any recommendations or anything we do, but promotion of NHS dentistry is something that in some boroughs you could do more of than others. In some you absolutely get, well, we can't find a dentist, but as I said, in Kensington and Chelsea, it's one of the boroughs where you do have the capacity. So we're able to sort of feed back to practices that have that capacity, and even the ones who are able to come back and say, you've got even more capacity. But just remembering some of those contracts could be really tiny. So it could come from somebody who's looking for a practice in High Street, Kensington, and 2 of those have got really tiny contracts, and they're finished in 3 months because they're so small, in comparison to somebody as much bigger one could be on the other side of Earls Court, for instance. So it's a bit of a mixed bag.
It's very interesting. Thank you.
Thank you. It might be related to Anne's point. It was the table, this one on page 27, the contracted NHS general dental services. Just from looking at this table, the contracted units of dental activity, is this sort of, because it's the lowest of all the boroughs. I just wanted to ask if that's appropriate for our population then.
Yeah, so you've got there's a number of things. So you've obviously got, it's a small borough relatively. So obviously that's why you've got a smaller number of providers. And obviously commensurately the contract value is spread across those 18 practices. But I think the key thing to note there is the final column is the UDA value. That's high.
Yeah.
Okay, and again, most of that is historic, so I don't want to go into the vagaries of how these contracts are arrived at, but there is no uniform UDA rate nationally. They are whatever they were following a reference period where these contracts were effectively arrived at in terms of value back in 2004-5.
Okay.
And each year, obviously, the DRB, which is the remuneration body for doctors and dentists, that they recommend an increase. So whatever your UDA value is will go up by that percentage. So that's that table just details, and obviously it's important. Obviously, so you've got a level of, you can see there when you look at the other boroughs by comparison, but each different, big and small boroughs across London, but it's relatively well served.
Does that mean then that any kind of inequalities that we might see across the borough are not attributable to kind of access issues?
Yes, in some respects. I mean, I think part of it is, and I think it's really important to note that when these contracts were arrived at, they are not based in any way on need or population. Okay, it's really important. They were arrived at, that was a financial exercise that was done. They're not based on need, and the reason I say they're not based on population, dentists are not constrained to see patients from a certain area. They can see anyone from anywhere in England.
Oh.
So ICBs, who we're now part of, pay for these contracts by virtue of the fact that they're located in this case, your borough. So North West London ICB pays for the contracts purely because geographically that's where they are. If that practice saw every patient from Hull, you'd still have to pay for it.
Okay.
Okay.
So does that mean then that the dentists within the borough can have patients from anywhere?
Yes.
Correct.
No, surely not NHS patients.
Yes.
Even NHS patients.
Oh yes, that's exactly. We don't get into private patients. NHS patients, and that's what I say, because there is no registration. They are free to see anyone that they choose to, and ultimately their only requirement is that they deliver the contracted level of activity.
To anyone, it doesn't have to be borough resident.
That's correct.
And you could have people who work in a particular borough and therefore they see their dentist where they work rather than where they live.
So there's cross flow in London.
Cross boroughs,
So you will have lots of cross flow in London, obviously, and bearing in mind it's a relatively small city geographically. So there will be a lot of patients from North Central London, South West London who go, but there will also be lots of people who come in from outside of London who maybe work here. But also, if you think about where you're situated, Hertfordshire, there'll be people coming over the borough, any of the counties that surround London, that they can see anyone from anywhere. And I think it's important to understand that the delegation of these services to ICBs make no difference, because legislatively the contract is exactly the same as it was when NHS England were the monitors of it.
I guess before I,
Yeah.
what worries me about that then is that because there are a number of dentists across the borough that will say, sorry, we're closed for NHS patients. And is there a way to kind of review to what extent that's to do with the fact that they are being overwhelmed, providing service for people who aren't borough residents who there's no way to know.
There's no way. Well, you could do some analysis. We can ask the BSA who actually ultimately monitor their activity. It can give you some data, but there's nothing you can do to change anything, because it's, as I said, it goes right back to their contract is to deliver their units of dental activity to anyone. And I think this is one of the conundrums, if you like, if you're talking about neighbourhood, population-based health. Actually, I'll be really honest, the three services that we look after, dental, optom and pharmacy, there is no registration requirement, and they are not constrained to delivering services to people who live in a borough or a particular
I
area.
mean, it's natural to think of that for an optometrist, but I had no idea that was the case for dentists, actually.
Yeah. So, and it is, as I said, that's how this contract works, and it's been that way since 2006. I think to give it some balance, the majority of people who go to a dentist will live locally, obviously, because that's the whole thing. But as I said, since we moved from NHS England across to being hosted by North East London to deliver this for the ICBs, I've had a number of people come to me and said, I want to know, our residents need this dentist. And I've had to say, well, you can put a dentist there, but he's not compelled to see your residents. And I don't mean that in any way facetiously, but they're just not. And that's the reality of NHS dentistry. So it's an activity based contract and nothing more.
I guess it's something to think about for those kind of underserved pockets of the borough then.
So it goes right to the heart of, until this contract is reformed, and it seriously does need reforming, none of this changes.
Yeah.
Okay, and I'm not trying to be the soothsayer of doing it, because actually we're real advocates for NHS dentistry, or we do commissioning, but that's the reality. And it's, as I said, the movement to ICBs means nothing, because this contract is exactly the same contract that sits under the legislative process that it was introduced in 2006. So I think, I'll be really honest, I think stakeholders and ICBs have been sold a bit of a misnomer around now. Following delegation, you as an ICB will be in much more control of, not as far as the contract's concerned, because they can't change it.
Thank you. Can I ask one more question about paragraph 8.14? The Vision 2023, the NHS North West London invested 98.5 in 315 NHS dental practices. Do we know very much about the impact of that for our residents? And
Which one?
Was it against?
Just double check.
Just double check if we've got that.
What I can say about that is, while we're just finding it, you tell me.
KNC, I mean.
So I think within the ICB itself, we can give you that detail, because basically there would have been a level of funding that was applied for, and what we were able to do is obviously allocate that additionally on top of the activity that's already commissioned. We reckon generally across London, we've probably seen an increase of between 3 and 6% in terms of activity. That's what it's brought us, basically. But what we can do is we can give you some detail.
activity due to the number of treatments or a number of new registrations?
It'll certainly be in terms of treatments, but it will also, we can drill down and tell you the numbers of unique individuals who've been treated, both adult and children.
Sorry, can I just ask one more? And it's about the looked after children and the DNA rates for looked after children, which just seems like an area that would, because it's not financially viable to continue with one of the services because the number of didn't attend for.
So that was the particular pilot I think you're referring to. Is that one? Yeah. So it was something that was certainly it was something that we did as a response to the pandemic, because there are services in place. It's an obligation for any child, obviously looked after, to be able to access a dental check when they move into a new area. Some local authorities have some quite long-standing relationships with practices, but our community dental service will quite often be the first port of call for those children to be given a dental check. What we did is we opened it up during the pandemic because we could see actually this is going to be a problem for people. Access to dentistry full stop during the pandemic was a problem, but these children needed it. So what we did was we orchestrated a process where any social worker looking after or responsible for one of the children could contact go through our dedicated triage service, and they would be directed to one of our urgent dental care hubs for assessment. I think 2 local authorities really motored on it. The rest we just didn't get any, which was a shame. And in the end, it ended up being a service that was utilised, but we ended up it was quite often utilised by the children of asylum seekers, because actually we didn't discriminate. We said, well, actually the service is available and you can take it up. It wasn't the intended population group we were aiming at. But again, I don't know whether that's how many looked after children actually come into London. I would suggest we're probably a net exporter of those children. So it may well be that we don't have masses, but it's hard to put a finger on it, really.
Portia, do you mind if I just ask a follow-up question to you? Is there any capacity at all for the ICB to provide additional services on top of contracts? So there's extra capacity.
So in terms of what additional, so I mean, I think ultimately it comes down to there's a level of additional commissioning that they can do, and obviously it just ultimately depends on what headroom they've got within their dental allocation. It's worth saying that the allocation they get is ring fenced. Well, what I mean by that is that has to be spent on dental services, so it can't be used for other things. And there is scrutiny on the ICBs, as there was NHS England previously, to ensure that that resource is spent. So it can't sit in the coffers and then be used to offset gaps elsewhere. But in most cases, the budget is fully utilised. There is a level of residual money that comes back in terms of underperformance. It's not massive, and effectively it's non-recurrent in nature. And when it comes back, that can be used for other things because it's already been spent once. So it's ultimately at their discretion, and I don't like doing this now because previously when we were NHS England, the onus was on us as commissioners. It is now individual ICBs, and it all depends on their financial position as to whether they're in a position to supplement what they already have.
It's worth just saying we have just submitted a report to all of the West London ICB to suggest we'd like to spend money on additional dental access and we're waiting for a response. So that's what we're sitting at the moment. But that's happened quite recently.
Thank you, Chair. Thank you for your report. I just wanted to know, let me see if I get this correct. So currently, are there any new practices taking new patients in RBKC?
So there are no new practices. Your existing practices should be
Taking on the NHS?
Absolutely.
Okay, thank you. And also, how are residents being informed about our urgent care options?
At the moment, we are working on, I laugh because it's something we've been talking about, so we really need to make sure the awareness is out there. We're finding people will turn up at the hospital or go to, we don't want them going to the place where they won't get seen or it's not the right place and they're going from pillar to post. So outside of the NHS website and the dental practices informing them and their phone lines, so if you rang your dentist, ideally, most of them, and we did do a check on this around 2 years ago, they should have an answer which says, if you're in pain and you don't have an NHS dentist or we can't see you, please call 111. When you bring 111 in, if you're located in London, not that you live in London, but you're located in London, it will say press 1 for dental and you'll go through to the urgent care service. Outside of that, we are currently promoting that. We're speaking to all the ICBs, and there is a poster that's being created. Actually, we're nearly there now, and we're hoping to get that out to all the GPs, their waiting areas, pharmacists, opticians, local care hubs, family hubs, local authorities have been mentioned on this. We've actually got a big list where we'd like to actually, dentists, pharmacies, and opticians, and then the GPs, so family hubs, etc. So those 3 services are within what we do. The doc team, so dental, pharmacy, and optometrist, sort of a standard. But outside of that, we wanted to go as far as we can. So we're getting thousands of these posters printed, and I hope for those to go out. We are speaking to the ICBs as well, because a lot of their websites they have where they've got pathways for patients. A lot of that is happening. Again, NHS Choices, if you go to NHS Choices, you go to London, it will say ring 111 for an emergency dentist, etc. So pretty much we're now trying to do a big campaign on this. Largely because you probably know about the government target that's come through about 700,000 urgent dental care appointments. In London, we haven't had to commission additional urgent care. We have the capacity, we have urgent care, and we have a practice pretty much in every single borough. In fact, in Kensington and Chelsea, I think you have 2. And these are practices that work daytime, evening, and in some cases up till 1 a.m. or 2 a.m. in the morning. So again, as Jeremy said earlier, really, really good capacity-wise. But we just need to make sure that people are aware of that service. So there is lots of work we're actually doing at the moment on that because we haven't had to commission the additional urgent care slots. We're actually focusing on the awareness of the slots. So saying to people, use these, they're available here for you. It's just worth noting that these are urgent care only. So if somebody goes in with a filling that's dropped out and they're in pain, then it would be a temporary filling. If somebody needs an extraction, for instance, it would just be, if it's a mobile tooth, for instance, they may extract the tooth, or if they need antibiotics, but they need to then go and find an NHS dentist. Some of these urgent care hubs do have capacity to see the patients in their own practice. So the patient could be taken on that. And if they don't, then they'll be directing them to the website as well. So it's just making sure these patients get stabilised rather than just coming in as emergencies, because you do have the cohort of patients who only come when they're in pain.
One more question. Thank you. And how much is currently spent on commissioning dental services in RBKC? And how is it split between prevention and treatment?
So the value is on one of the slides. So yeah, so you've got that's the units of dental activity. I can give you the figure because this is all activity based. There is no split between prevention and treatment. No, because of the way the contract is. Dental charges are split between bands of treatment 1, 2, and 3, and 4, which is the urgent care. Within those bands of treatment, there's a level of prevention So, one of our band one will do things like a scale and polish, and oral health, general oral health advice. It's not split like that. The prevention side of it is effectively with our local authority colleagues. If you're looking at budget for oral health promotion, I think it's just important to say around the urgent care that Kelly referred to, what you have in London is unique. The urgent care delivery that exists in London does not exist anywhere else in the country. So what I mean by that is you go through 111, you are triaged, and if you need treatment, you will be seen. Without question, because we have a universal service. You may not necessarily be seen depending on what time of day you ring up in somewhere closer to you, but there is flex in the service now, which means that you might not want to run across London at 12 o'clock at night because the only available one is miles away, but you can go the next morning. So there's a level of flexibility there. It was ramped up considerably during the pandemic. We always had an urgent care service, but it was evenings and weekends and bank holidays. It is now triage is 24/7. And to give you some semblance of the demand, obviously at the height of it during the pandemic, it was 2,500 calls a day. We're still around the 1,000 call a day mark. So we have up to about 500 appointments a day available. They're not all being utilised at the moment. So part of that is around the constant drive we need to do to actually make sure people are aware the service exists. But on the same token, we recognise that the demand was there. We couldn't just withdraw it when the effects of the pandemic came to a close. So urgent care delivery is a single plank of delivery in London. If you go outside of London, if you try and access dentist out of hours, good luck. It's really difficult.
Thank you.
I've got a few questions. Starting with care homes, which I think you noted that 73% of residents screened had gum disease. And just understanding the pilot that we've been doing there, which I think was in 3 out of 9 care homes, and what sort of continued plan is with that, whether that's ongoing, whether we will be able to roll out more care homes, what's given these are very vulnerable patients, how we plan to.
So the intention is to continue with that work and to cover all of our care homes. And that this is very much providing us with the intelligence to inform the system about the nature of the challenges that our care homes face. And we're wanting then to really look at embedding better oral health within our care homes and ensure that we have the mechanisms for training to maintain that, recognising that there's often significant turnover of staff in those premises and an ongoing approach to this review.
Sorry, I've come in as well. My name's May. Sorry, I was late. I'm clinical director for the community dental service, so I work closely with these guys. We deliver oral health promotion in the borough, and we're supporting with this. We're delivering the pilot for care homes, and we work closely with Marina. And I understand she can't be here today, but we had a lot of discussion around the design of that pilot because we had one model going where we were delivering education to staff, which was great, but we didn't know what the need was in the care home. There's obviously unique problems in that you get a lot of patients who have dementia, mobility issues, so they may not be able to access GDPs. So we had 2 pilots. One was around education. The second pilot was going in and doing oral health assessment, and that's given us really a lot of data around, if patients needed extractions, could they access a normal dentist, and then we would help to signpost to get access to normal dentists. How many of them needed community dental services? So would they need transport, hoisting, or could they not leave the site? So would they need domiciliary care? And prior to this pilot, we didn't know that level of need at all. So it's quite small, but from that, we're gathering so much intelligence around the need. And we've got the education arm. And what we're actually doing, we've been working closely with local authority is we're doing the education, but we don't know if that's being implemented. So we're going back in to collect some more data, and we're looking at, there's obviously a chart to say this person has had their mouth cleaned today, but we're also then inspecting the mouth, looking at the quality of brushing, looking at the plaque on the teeth, and gathering that data. So all of that will be really useful, and then obviously we hope that that can continue, but we needed that data first to know the need.
Yeah, so it will hopefully be rolled out. And then just in terms of wait lists, which I know that there's no data on here on that, but what generally is the wait time when someone is trying to get? Do we have any
It
insights?
varies, obviously. Practices, certainly, some practices hold waiting lists. Most don't. And I think, like Kelly said, so the general view around, certainly, particularly in this borough, you're probably looking at 2 to 3 weeks for an appointment.
And with that, is there, from what you've been talking about, do you think part of the problem there is just the comms plan of people not knowing about if it was more urgent?
I think that experience most practices would
Let them
usually be a week or two ahead. It's kind of standard practice.
Yeah.
Most practices, and some somebody who's worked in practice. So
Yeah.
a couple of weeks usually you're booked ahead as an average. So you may have a cancellation, but otherwise you're usually booked up by a couple of weeks. And then again, it just goes back to the area you're in. So it could vary. You might have somewhere you might be able to see next week. And also the third thing, I know I've repeated it a couple of times, but it's just again to talk about the private element in KMC. So they might be that 50% of their book is private, 50% is NHS. So they're limited appointments, which is why they might end up waiting a couple of weeks for the NHS.
And then going back to the sort of the lack of registration, the way that this contract works, how are people, how often a dentist communicating and reaching out to people for checkups in the way that private dentists would, but surely that sort of prevention aspect?
Yes, they do.
Does it?
If they've got a stable base of patients, then they would do that.
Send out a recall. Which
Which
is just informing patients, usually based on the NICE guidance, which could be when the patient actually needs it. So when the treatment ends, usually what would happen is the system would actually say this patient doesn't need to be seen for 12 months. It doesn't always have to be 6 months. It could be 3 months because of oral hygiene. It could be 6 months, it could be 9, 12, 18. And therefore, they usually have a list at the end of that month which says, here's all the recalls for that month. That's kind of standard practice for NHS.
Okay. And that's the same with kids too.
Yeah, particularly with kids. Yeah.
And then I was just going to touch on what you spoke about in terms of the A&E statement with what they said about young kids and why that is and what's being done.
So we do run certain programs to encourage people, obviously, to support our NHS colleagues on how people can brush their teeth properly, how people can understand better oral health. Some children, of course, especially young children, don't necessarily have that. They don't necessarily have the parental guidance. Parents don't know themselves. And there is a certain way you need to brush your teeth as well. I've been to the dentist and I got in trouble for doing mine wrong. So so therefore, it's not a simple thing. I'll give you an example now. Absolutely. So in part of our program is to do that, and as we mentioned in the report, we've recently done one at Colville Primary up in Woodville Road. That's a bit of a test case in order for children to have that as professionals come in to say how we can kind of do that to improve oral hygiene and health. Of course, there's only so much a school can do, and obviously you need to do it at home as well. But there's certainly sections of the community that we really need to target to ensure that they can get particular programs in terms of their healthcare, in terms of how they can treat their dental conditions as well. And a lot of it, as well as the report highlights, is people perhaps having a fatty or sugary diet for children especially, and when it goes to adults as well, more kind of smoking and alcohol, which also does degrade teeth, obviously, for various other reasons. And also we've got a particular element there about how helping treat homeless people as well, in order to sure that they can have the best dental health care as well. I don't know if you're thinking,
Yeah, and May might want to come in as well. So we very much take a life course approach to oral health. So it starts really, really early on with encouraging and promoting breastfeeding. And then we work very much with our health visitors. We commission health visitors, as you know, for the population. Our health visitors would very much talk about weaning to young mothers. They would talk to them about when to start cleaning babies' teeth, and it's a lot earlier than you think. So using a rag when that kind of first tooth appears, and then moving on to different types of toothbrush as the child gets older. They would encourage sippy cups, so moving to sippy cups rather than bottles, always talking about milk and water, and offering milk and water as the preferred choice of drinks right the way through childhood for our children and people. Coble School, which Councillor Rendell referred to, I think is a wonderful example. If committee members haven't watched the video, please do watch the video. You will see the headmistress talk about moving towards a water-only policy at the school, having water available, work they've done around the diet at the school and the menu at the school to take sugar out of the diet at the school, the importance of having champions in the school that can champion oral health. And then you'll see them doing the supervised toothbrushing with children and young people. You're also aware of our family centres. So our oral health promotion service will also work in our family centres, again, having conversations with mothers, fathers and families about how to maintain good oral health, speaking about the twice daily toothbrushing with a fluoride toothpaste, speaking very much about reducing sugary snacks, eliminating as much sugar from the diet as possible. And again, very much around water, around drinking utensils. We provide toothbrushes, toothpaste at our family hubs and via our schools. And we also provide sippy cups. We've recently received funding from the Department of Health to expand our oral health programmes. We're looking at expanding those across our early year settings. Previously, our work was very much targeted on areas of deprivation, and particularly those children, young people, families where you were much less likely to be accessing dental care. But we're looking at expanding that now across into childminders, as well as into the nursery settings, and as well as into the school settings. It's been quite exciting to expand the work across into care home setting. We've already spoken a bit about that pilot, but other areas of work that are particularly important for us, as well as the homeless population. We've work very much in our hostels, and the health promoters go out into the hostels, again providing toothbrushes, toothpaste, giving advice on oral health and where to receive dental treatment should dental treatment be required. Again, there's a video where you've got an opportunity to see work taking place at St Cuthbert's, and again I think that's a really useful video to watch. Oral health is a part of the statutory responsibilities of the council, so particularly in terms of undertaking needs assessments, which May referred to, in terms of understanding our need in the care home setting, in our children's setting. The quality of data, as Jeff mentioned, is quite poor in relation to oral health, and one of the things we struggle to do is to get a big enough sample in national oral health surveys to be able to make valid conclusions about our population's health. So hence that link around diet and obesity is one that we very much.
And on that, the survey and the data, is how do you address that in terms of knowing, I mean, pushing, how it pushes your strategy? How do you get more survey or get more data so that you know that what we're actually doing is effective?
So one of the things we can do is purchase a supplementary survey in addition to the routine survey that's undertaken. And moving forward, we've got plans to identify funding to purchase that supplementary survey. And that supplementary survey will give us a bigger sample size, and that will enable us then to get a statistically significant sample size. May, I don't know if there's anything you particularly wanted to emphasise.
Yeah, I mean, I think we've covered a lot there. A couple of things is previously for data, we could get it now, we need positive consent, whereas before it was opt-out. So that means the number of families, parents agreeing to the survey is, limited because that's just to collect data. So their child would then, have to engage in that. So it's challenging, but that's across the country. A couple of points is Central London Community Healthcare Trust has the oral health promotion contract, but we also have the community dental services contract, which includes a homeless service. So because it's all within our organisation, we actually give access. So if one of our oral health promoters sees a child in a family hub or sees a mother who's finding it difficult, or they can tell they're going to need a community dental service treatment rather than general practice, that referral will come in rather than the patient having to go to a general dentist and then coming to us. So it's actually improving the access, and the same with the homeless services. We would then facilitate an appointment into the homeless services.
Thank you very much. Any other further questions? Thank you all very much, and that was really, really insightful and absolutely very reassuring to hear that we're doing generally very well as a borough, and we have much more access than maybe we necessarily knew about, and particularly in comparison to the rest of the country. Thank you so much. Thank you very much.
Just mention, I did get a monthly update on those dental surgeries that are accepting patients.
Yeah.
Month by month. We can make sure that that's circulated more widely. I'm sure that will be helpful.
Yeah, that'll be great. Thank you very much. Moving on to agenda item 5, which is community pharmacies. This report provided by the Local Pharmaceutical Committee provides an update on issues and pressures affecting pharmacies in the borough. Please welcome Pritesh Patel, CEO of the Local Pharmaceutical Committee, and also the meeting tonight. Very much for coming, and then also my Councillor Jeffrendal and Anna Barley again. Pritesh, do you want to just start by
Yeah, hello everyone. My name is Pritesh Patel. I'm the CEO of Kensington Chelsea and Westminster LPC. Do you want me to do a little introduction? Yeah. So, thank you for the invitation, Councillor Knight, and my full report is in the papers, and there's a lot of detail there, and hopefully all the committee members have had a chance to read the report. Councillor Knight had 3 main questions she'd asked me to sort of present on, and which is in the report, but I'll just quickly sort of do a brief summary of what I've written in the report. The first was an update on the national contract for community pharmacies and the local implications. What was the local flavour on that? So the report details the funding for 25-26. So the government only agreed to 1 year of funding. So 26 onwards, it's still being negotiated. But the funding for this current year was very welcome because things were getting really bad in the pharmacy sector in terms of funding. And if this funding hadn't come through, we would have seen a lot of pharmacies go under. But we really need long-term uplift to make sure that pharmacies are financially secure. So there was a report done by the independent, there was an independent economic analysis done by 2 independent bodies, and it was commissioned by the Department of Health. And that says that we still need another 2 billion a year for pharmacies to make them financially viable. So at the moment, the contract is just over 3 billion. So it is well thought of what's needed. And pharmacies are struggling, and they can't rely entirely on NHS. So in Kensington and Chelsea, what we have is pharmacies are, I suppose, slightly lucky in the sense that they can sort of diversify into private services. So you have private prescriptions. So there's a lot of private doctors in the area, and we have private dispensing and private clinical services as well. So things like travel vaccinations, and there are a lot of other sort of private services that can be provided, which are keeping the pharmacies in RBKC afloat. But even then, there's still a lot of pressures, as evidenced by the decision by. But this is the second question that Councillor Knight wanted me to answer, is the decision by Tesco's to close. And, are there going to be other closures of pharmacies soon? And is it going to affect the local network? Now, Tesco was a little bit unique in the sense that it had what we call a 100-hour contract. So it was obliged to open 100 hours in a week, very long hours. So it would be like 7 o'clock in the morning to 10 o'clock at night, 7 days a week. That's really long hours. And to find staff to sort of manage those hours is quite difficult and challenging, both in terms of finding the people and then paying them. So recently that 100 hours has been reduced to 70 hours, and Tesco's would have known that. But even then, 70 hours a week is still long hours, and they still have to open on a Sunday. So unfortunately, large multiples like Tesco's working in a supermarket wouldn't have access to the private services or that extra income that other high street pharmacies might have. And it was a national decision by Tesco to close a number of their 100-hour pharmacies. So our local network is still very strong. There is still other pharmacies locally around Tesco's, which can sort of take up all the dispensing volume and provide all the other local services as well. But there are still dangers to pharmacies closing. Just for example, we have Stickland Pharmacy in South Kensington is in the danger of closing. That's because that's within the station, and TfL want to develop the site. And I think some councillors are probably aware of this. And it's not easy for the pharmacy owner to find premises, new premises, fit them out, and all the associated costs that come with that. So I wouldn't say that there isn't any danger of any pharmacies closing. There always is. The other factor is that a lot of pharmacies, especially independent pharmacies, would have bank loans for anything from 10 to 15 years, which they have to make sure that they pay. And so they can't just suddenly decide to close the pharmacy because the bank loans still remain outstanding. And a lot of them will have leases, 10 to 20 years lease. And that they suddenly can't just stop paying back. They'll be liable for that. So very difficult for a pharmacy just to close shop without absolutely going bankrupt. So they will sort of cut back on other things. And usually, the first place with main cutback is the staff that they have. So an example would be that, community pharmacies would pay the national living wage, but very few would be paying the London living wage, for example. It's just not, they just can't provide that. They can't afford that. So we have had 10 pharmacies in Kensington, Chelsea and Westminster closed since 2020. And out of that, 2 of them were in RBKC, and both of them were the Lloyd's pharmacies in Sainsbury's. So those are the only 2 locally that have closed in the last 5 years. And I suppose it's in my report that one of the major issues with pharmacies in RBKC is the high rents and the extra high rents and the rates as well. Rates are particularly high. And this is where, if anything, the council can probably help out, sort of make sure that the network remains. So, but that's obviously a longer term conversation. And then the final question was that this new service, Pharmacy First, how is it performing, and are the local residents benefiting from that? So I'll put it quite a detailed description in my report. Activity levels are very low, and all the reasons are explained in the report. And the uptake and the increase of activity of the Pharmacy First service remains a priority for the LPC, not just to make sure that all the residents, get the services that they want, but to make sure that pharmacies, are not losing out on income. So that's just a brief summary, and I'm very happy to take any questions on anything in the report. Thanks.
Thank you very much for your session. Thank you for coming. And I think we all appreciate how difficult it is for your businesses. I'm sure we'll get into questions on that in this paper and with Josh. I think I just wanted to start by talking about Pharmacy First and just looking forward. I know we're performing much worse in comparison to the rest of London. How we're planning to change that around, why, what is, I know you listed a lot of the issues there, but what we can do quickly to make a difference there. And then in addition to that, the opt-in of the new contraception access that's coming in. I know that it's going to be opt-in, but what kind of work can we be doing as a borough to sort of encourage pharmacies to opt into that? Because I think there's a significant difference between us and, say, for example, Westminster, where you can walk in and get really emergency contraception, and listening to your work around that.
All right, so I'll answer the emergency contraception question first. So we in RBKC and in Westminster, we don't have a pharmacy EHC service, emergency hormonal contraception service. I think there is a local service, but that's limited hours, but we don't have a pharmacy service. So I think most pharmacies will opt in to provide that service from October. I don't think very few will not sign up, because it's a relatively easy service to provide clinically.
Yeah.
And it doesn't take much time. And almost every pharmacy in RBKC has a consulting room, and that service can be provided very easily. So that's something to look forward to. And that particular service, the EHC service, would tie in neatly with pharmacies providing the contraception service.
Yeah.
So then one of the new services that came with Pharmacy First is the contraception service, where pharmacies can initiate contraception, hormonal contraception for women, or they can repeat their prescriptions.
Yeah.
So that's the contraception service that will fit in with the EHC. And in terms of Pharmacy First, how are we going to increase the numbers? And I think the key thing here is very few patients and residents are aware of the service. So if you went around the room now, very few people would be aware of which are the 7 clinical conditions that you can go straight into a pharmacy and get consultation with a pharmacist.
Mm-hmm.
And in many of those clinical conditions, you can even get an antibiotic if it's justified. So an example was that a few weeks ago, my wife had a urine infection, and she was like trying to get hold of the doctor. And I said, you don't have to. You can go to the local pharmacy. So if at home I haven't managed to sort of get the vaccine, I can imagine that the residents don't have a chance. So I think the NHS obviously are funding this nationally, and it's for them to make sure that patients and residents are sort of aware of these services. And the other big obstacle we have is some of the pharmacy first services need a referral from the GP. So this is the minor illness side of the service. So the 7 conditions, anybody can just walk into a pharmacy, they don't have the referral. Yeah, provided they're within the age limits of the services. But for minor ailments part of the service, patients can't just walk into a pharmacy. They have to be referred from either the GP surgery, urgent care, or NHS 111. Now, those referrals are not coming through for a variety of reasons. One of them is mainly that the integrated IP solution does not exist, or if it does, it's very cumbersome. So say, for example, if a patient went to a surgery for a sore throat, for example, it should be very easy for the reception staff to figure out that this sore throat patient can easily be referred to a pharmacy. But when you look at the process that they have to go through, most don't bother and they just book the patient in, with the doctors. The doctors, or it could be the same day or it could be in a few days' time. So that referral process from GP surgeries is not working. And at the moment, the ICB is trying to improve that. So they have given us a little bit of funding for us to engage with the primary care networks, just to make sure that they improve the way GPs are referring into the service. So again, NHS 111 can refer into the service, but I mean, we're getting very few referrals coming in. So it's the algorithm at NHS 111 that's not great either. We can get referrals from urgent treatment centers, and I think that's all the sort of pathways of referrals, but those referrals are not coming through, especially in Northwest London. But in other areas, say like Northeast London, they have set up better referral mechanisms, and the activity levels are much greater for pharmacy.
It falls with the ICB in terms of the work they're doing and the additional funding.
That's right.
Yeah. It should turn around.
Yeah.
Okay.
So I hope that answers the question.
I've got more questions, but I'm going to go to others because I shouldn't speak too much.
Okay. Thank you. I just wanted to know, I've got 2 questions for you. What target efforts are being made to address the reported health literacy gap among vulnerable groups, not casing?
Which groups? Sorry.
Vulnerable
groups. So by vulnerable groups, are we talking about patients who can't afford medication? Yeah. So there's
access. So, for
access,
example, disability.
I think most pharmacies, in terms of disability, I think most pharmacies would have easy access, for these disabled groups. But for residents who can't afford medication, I raised this at the last committee meeting that I attended, and it's a particular concern of the LPC and community pharmacies that a lot of times we get patients coming in, we recommend some sort of medication to them, and they can't afford to buy it. It should be something like, for a backache, we just say, look, we can give you an anti-inflammatory gel, and that will solve the problem. And unfortunately, they can't afford the £5, £7 that you need to buy that, and they would end up going to the GP and get a prescription, and then they will be exempt. And like it sort of mentioned at the previous committee meeting, there are other parts of London, Northeast London and North Central London, where there is a pharmacy scheme where vulnerable patients can go in, and if they can't afford the medication, usually it's patients on universal credit, they can get, say, for example, this anti-inflammatory gel free of charge. So it is an issue, definitely.
Thank you. And also, I'm quite confused because in the PNA report, it states that there are no current or future gaps in pharmaceutical service. But then, yet in the LPC report, it highlights services uptake and operational risk. So how are we going to reconcile this conflicting narrative?
So most of the pharmacies provide all these services, and they're just waiting for patients to come and make themselves avail themselves to these services. Just like I said, it's just that those patients aren't coming in, or the patients aren't being referred. So when you look at the PNA and you'd say that, is there enough provision of pharmacy first? Yes, the pharmacy first provision is there. It's just that we are not getting the footfall of patients coming in.
Okay.
Yeah. So there isn't a need for any more pharmacies provided. There's adequate provision, and so there isn't a gap.
So the LBC's got funding pressures with low service uptake while the PNA needs people to come in, yeah?
So it's the pharmacies need more patients coming in, and the PNAs find that there's adequate provision.
Okay. Thank you.
Thank you. The first one was just a really simple factual one about the investment from the ICB. It looks like it's among the lowest in terms of any ICB in London, Northwest London. Do you know why that is? Is that because the population again staying small?
I think it's just the priorities that different ICDs are given to community pharmacy. So some ICDs have invested in community pharmacies, and some, like Northwest London, haven't. So it's as simple as that, and it's where they've allocated the money. So
and would a kind of adequate or an uplift in the investment to bring it in line with other similar boroughs, would that help with the access issue of and the awareness building?
It would do. So
because that would in turn take pressure off NHS services.
It would take pressure off GP service, GP services, and a lot of these conditions can be treated in a pharmacy straight away, same day, without having to wait maybe a couple of days or whatever. But it's where the ICD sort of wishes to prioritize their money.
Maybe you need to embed yourself in the GP surgeries and then just have people diverted. The other question I had was about obviously these are businesses and they need to be kept afloat, but the description, or perhaps I haven't understood it fully, the potential prioritising of the private work and the way in which that might kind of disadvantage some groups within the borough, and potentially the closure of, or the kind of reduced opening hours, was it?
Yeah.
And obviously that's a cost saving measure, and I was interested to know if there were any specific wards or specific pharmacies that you felt were at more risk than others, and what could be done to keep those open.
So we're doing a piece of work as an LPC, sort of engaging with all the pharmacies in RBKC and in Westminster to see how ready they are for providing these extra services like pharmacy first service. Most of them, the dispensing is fine. The dispensing, somebody goes in with a prescription and it's done and it's dusted. But a lot of them are either not ready to provide extra services, or they feel that the extra services is an investment too far for them, too much for them, and then they'd rather just focus on private services or selling over-the-counter products. So, say for example, a small pharmacy might have a pharmacist and maybe 3 members of staff, and to increase their offer of these new services, they might have to get an extra member of staff, because like a technician, so the technician could look after the dispensing side of things, so the pharmacist is freed up to provide NHS clinical services. Now, all that, you're going to invest in your workforce, and obviously it's at the risk to the pharmacy, and many are not prepared to sort of take that risk. So you're going to think ahead. So to do that, you might have to invest, say, in hiring a technician, and that would be like 30,000, 40,000 pounds a year, without any guarantee that all these extra services are going to come in. The ones that have done it, are seeing that, that they're getting a lot more services coming in, and they're able to provide not only NHS services, but even more private services. So you're right that there is a business decision to be made as well as, the commissioning side of things as well.
And is Pharmacy First in any way, I mean, how income generating is it for a pharmacy, if at all? Is it worthwhile?
So it is useful income, but if you consider that, if you look at the NHS business as a whole, dispensing will still be in RBKC, dispensing would account for 85% of the turnover, and the services would just be about 15%. So, you'd have to sort of invest in staff, and sometimes you would invest in equipment, invest in a consultation room, or even a second one, just for that 15% turnover. Whereas dispensing is a lot more established and easier to do.
Yeah. I guess the reason I'm asking is there something about Pharmacy First that's not lucrative enough for it to be?
There is something about it, because you've got to balance it with the investment in workforce and the investment in your premises as well.
Can I just ask one more, just in relation to that? It's page 65, 7.2, and it comes back to this question of, obviously needing to prioritise governmental decisions and promoting private services and over-the-counter sales, or to promote NHS services. And I just wondered how that balance is being struck at the moment. Like, where is it lying? What's happening?
So if we compare ourselves, this borough, to the rest of the boroughs in London and the rest of the UK, we are last, or second last in terms of activity. In terms of activity per resident, we are very low in activity.
Sorry, for what? For the pharmacy?
For the pharmacy services, for the Pharmacy First services. So
Is there a reason? Sorry, do you have a reason for that?
So the reason that I've kind of listed in 7.2 are the factors that
Essentially, it's not lucrative enough at a time when you're under a lot of financial pressure.
I know, and the thing is that we are sort of, as an LPC, we have our frustrations as well, that why aren't our contractors taking up a lot of these services? But they have got a few challenges as well. It's not always within their gift to sort of get the patients in. So, they could be offering the service, but the patients aren't coming in.
Do you wonder if there's a case to be made with the ICB then?
Well, and the ICBs are well aware of this, but they need to prioritize, community pharmacy to create the next step.
I was going to say, just in terms of going back to business rates, this borough, what Mana's just been bringing up, if there was more support there, for example, not necessarily saying where it's coming from, could all of this work better in terms of people would be less stressed in terms of Pharmacy First? Maybe you would be able to take on more, where I do think there is a gap in terms of, you can bring up with Josh and Anna in terms of services that are being performed. I mean, it's 16 out of 38 pharmacies that are providing smoking station services, and 23 out of 38 pharmacies are providing blood pressure. So, I mean, there is a lack of the additional services being provided, which I don't think the P&A reflects. Well, do you think sort of all of these services and the kind of position of pharmacies would be better if you weren't essentially in such a passionate position of wanting to keep your businesses afloat? Is that impacting?
I think so. For the last 5 to 6 years, definitely, pharmacies haven't been able to invest into their premises, definitely, to upgrade them, to make sure that, that the workforce that they have is ready to take on all these new services. So, like I said before, if you've just got a pharmacist and a dispenser, chances are it'll be very difficult for you to do a lot of these services. You need a technician in addition to those two members of staff. And at the moment, until now, pharmacies, would find it very hard to invest in an extra member of staff.
And do you think that is partially because of the excessive rates that we experience
this is the
in
thing.
comparison to other? If we're looking at pharmacy first and why that, well, do you think that's a reason?
It's a big reason. The renting rates, eat up a lot of the income that pharmacies are generating, and end of the day, a lot easier to sell a bottle of vitamins, for £15 than to provide a pharmacy first service for £15.
So that's Agneta.
Thank you, I'm sorry. Yeah, I mean, you mentioned 7.2. I mean, the suggestion I get from 7.2 is that if anything, we seem to have too many pharmacies. The bullet point you said we have a large number of pharmacies per capita. There's fewer NHS pharmacies. We've got more than the rest of the country. And you say the pharmacies dispense on average, I mean, half the number of items per month in the rest of the country. I mean, I assume you're not telling us that we have too many pharmacies.
So we've got an adequate number of pharmacies, but even within those pharmacies, the amount of NHS services that are being provided at the moment, especially pharmacy first service, granted that pharmacy first service has been only around for the last 18 months, it hasn't developed as much as we would have hoped, and having the high number of pharmacies per capita doesn't explain it. I think because we still have a large resident population, but we should really be able to do a lot more. So it's not just because we're in a good position where we've got enough pharmacies that's the problem. It's just that the residents are not accessing the service for various reasons.
But when you're talking about the number of items dispensed, that's not just pharmacy first items.
That's just prescription items.
Right. So given the particular demographics of our borough, where more people than most boroughs use private healthcare, they would still be coming pharmacies, presumably they just get a private prescription.
Yeah.
So why, given as you say the population numbers, I mean, what do you think why is the dispense of items so low? That's why I can't get my head around.
So there is only going to be a certain number of prescriptions, from the NHS in a certain area. And if you've got fewer pharmacies in that area, then they'll be doing a larger number of prescriptions. If there's a higher number of pharmacies, then they'll be doing proportionally fewer NHS prescriptions. And then relying on.
This isn't just NHS prescriptions. This is all the 4,361.
No, that's just NHS.
That's NHS.
So the LPC really just focuses on NHS services. So that's what we're there for. And obviously, we understand that the contractors that we represent, are doing all the private services as well. So
do we have any idea of how many private prescriptions they dispense items for?
So it's in terms of items, I wouldn't know, but I do know that private prescriptions and private clinical services are the reason why our BKC pharmacies are still surviving.
But, okay,
they couldn't survive on NHS.
Yes, yeah. Right. My point really is that again, I mean, it's not the first time we've had a report where the numbers that are in the report, because they're just NHS, they don't take into account, I think, the particular demographics of our borough and the fact that actually probably a considerable number, if not a half, of people getting items are probably getting them through private healthcare, right? So I mean, it would be helpful if there's any way of tracking or finding out how much business pharmacies are doing For private.
You're quite right that we are saying that the activity is low, but we obviously, we are not in a position to map is, are there residents who are in need of services who are not getting the services? And we have no way of tracking that. So.
Sorry, who are not getting the service because
Because of whatever
the
reason, it
priority
could be,
is for the private work or?
so they might be buying items privately rather than, using an NHS service, but it could be that, like I said in the report, that they're not aware of an NHS service that, they can use. So, difficult to map that. And I don't think the NHS does any work on that, or even the ICB does any work.
Could we ask them to? Could we ask them to contact, I mean, there obviously aren't that many pharmacies. Could we ask
them.
the ICB or whoever to try and get some data on pharmacies about, the pharmacies will obviously know how many items they're prescribing.
Yeah.
I think to get a fuller picture of the data is important.
I mean, in the
I'm not clear
report,
what data is missing or what's the point I'm making about it, sorry.
You're talking about the private prescription.
Yeah, so we're talking about prescriptions, the number of prescriptions and items you've got there, but it says that we're much lower. It makes it seem like our pharmacies are being used less than elsewhere.
The pharmacy first stuff.
Just in general, I mean, this item is not, what's come up here, I think it's all prescriptions, not just pharmacy. But I mean, that's quite a stark number. It's half the rest of the country. And I just think if there's something we can do to tell the ICB, or the other, if you can use this on.
I think
to try and get
the most useful thing would be if you wish to contact the ICB and make suggestions to them, is that they need to work with pharmacies to make sure that the referrals coming in from GP surgeries are increased. We know for a fact that the GP referrals coming into our pharmacies are very low as compared to other parts of London, and we know that
these are not private referrals.
No, these are just NHS.
Yeah,
just NHS. Yeah. So it's very low, and that can be improved quite a bit. And I think the main thing is that why would you want the GPs to refer into a pharmacy service? It's basically to help the patients. Patients can get same-day access, by being referred into a pharmacy service, rather than having to wait for a GP appointment.
But when you say the referrals are low, you mean as a sort of gross number, right?
Number, that's right.
Yeah. So, but the fact that if you were hypothetically, if a borough existed where everyone was on private healthcare, the number of referrals would be zero. So you'd be sat in this room saying, "Oh, the numbers are very low. It's terrible. We've got to get the numbers up because no one at all is being referred." When actually everyone is on private healthcare. So, and I think that the nature of this borough, and again,
not everyone is on
no, but that's the thing.
private
But
healthcare.
we're talking about these numbers being
about
low.
very simple kind of medical needs like an earache or something that you can just pop into the pharmacy.
But we can't say that the numbers are low when the figures are excluding. I agree, not everyone, but it gives a distorted picture of the borough and of the services that they're being provided.
I think the point is that there's a resource available and there isn't sufficient uptake for it, and we're trying to get an understanding as to why that uptake is low.
I think we can make a recommendation as a committee to the ICB to review effectiveness of pharmacy first.
That's right.
And GP referrals and patient awareness. And also we can ask if they can shed any light on the data you're talking about, so that states and bigger pictures to what the bucket is. I'm just going to move to Anne.
Just without wanting to sort of flog this question anymore, just so that I understand, you talk about the uplift in the funding. Is that for Pharmacy First, or is that just a general uplift?
So Pharmacy First
they do get money for Pharmacy First.
Yes, they do, and then Pharmacy First is part of the figures that I mentioned in the uplift. So part of that money is the money that they've set aside for Pharmacy First.
Because I guess what we're all sort of trying to get to is how can we support these pharmacies and their businesses, and they need to survive and they need to thrive. And it just seems to me that we're asking them to do more Pharmacy First, which is completely sensible. Taking the pressure off the NHS. So it feels like they should be able to make money out of it. And all the reasons that you give for Pharmacy First, having having the lowest uptake in our borough, seem to me to be quite generic issues with Pharmacy First. There's nothing that's specific to RBKC that you're ascribing here. So I guess I just don't feel like we've really got to the bottom of why this isn't an income generator for them. Why wouldn't the GPs want to refer patients? Is it because they're losing money by referring patients?
The way the GP contract works, the number of patients that they see is not income for them. It's not like the dental contract or a pharmacy contract. So they get paid according to the list size.
Right.
So
it seems like a no-brainer that when you call up to, get your GP appointment and you're asked what the problem is. If it's one of those 7 things, it should be straight to
exactly
Preston and Hawthorne High Street Can or Boots. That's what it should be. And they should, both Boots and Preston and Hawthorne should have a massive poster in their window saying, if you have any of these things, come here. It doesn't seem, I know it's probably not as simple as I'm making it, but it doesn't seem that complicated.
It should be much easier. And there are systems coming into play where, when you contact the GP surgery, some of them have this online portal where you go into, like it's called eConsult. And then some of those eConsult programs are now sort of saying that, you can go to a pharmacy, for the condition that you just explained. And then a referral will go to the pharmacy automatically. But those are still being developed, and not too many surgeries in RBKC have got that.
Yeah, I think we can make a draft recommendation as a committee to the ICB. I'm gonna quickly, because we do technically have another.
This one is very important.
Because it relates to Anne's point. Can I just quickly? I was like, it was just about whether, let's say, Anne's recommendations were put forward, and actually we did see an improvement in the uptake of things like, Pharmacy First for all of these conditions. Are the pharmacies resourced enough to be able to meet that demand at the moment? And would there be any impact on their income or
all the pharmacies that have signed up for Pharmacy First, I think about 80 to 85% have signed up, and they will be ready, because that's part and parcel of how pharmacies work. They work on demand basically. So they'll be able to manage that.
Okay,
yes.
so the stuff you were saying earlier about, needing to have a space in the pharmacy, additional technicians, additional staff, that's not going to be.
So, the 15% who sort of said, you don't want to sign up to Pharmacy First, they've got concerns like that.
Right.
That they don't want to scale up their business to take on additional business.
And not so funding should be about helping them scale up.
Yeah.
What I wanted to ask you about the public survey that 37 residents and workers responded. The survey.
I think we've got another paper after. That's why I'm trying to.
Yeah, in the PNA.
It's the PNA.
Yeah.
It's the next paper.
We might as well just get it out and.
We can just open this up as one if we want to do that.
It's the same thing.
Yeah. No, okay, well let's include that, and then we can just address all, because it's actually you okay.
I can stay for another 10 minutes, but yeah.
We're just also including agenda item 6, which is pharmaceutical leases, which is cautious. Yes.
Thanks, Chair. So we have to, as a health and wellbeing board, consider an updated pharmaceutical need assessment through the PNA. The health and wellbeing board, which I chaired back in May, initially considered the draft consultation, which is up in front of you at the minute. And the point of the PNA is obviously very similar to what the questions I think we were earlier about where the future direction of pharmaceutical needs may be for RBKC. That looks at things like demographics, change of population, where some of the health concerns may be borough-wide, and capturing views all people may not see. Of course, we've got on there, this works alongside the Grenfell JSNA as well. So, of course, with the future of the tower, obviously being coming up shortly, and all that as well, that is copied in the report at the same time. We also looked at the consultation, so we looks at pharmacies where they're based around the borough, and a bit of breakdown on where they are, how they're open, whether that meeting is suitable. I'd point out, for example, just on that front, that I think Brompton Hansard has 4 pharmacies open late, while the rest of the borough, for the most part, only had 1 per ward. Is that appropriate, etc. So, that's what the PSA attempts to do, to kind of fill that all together and work with health partners then to ensure that kind of comes out from the front. I don't know, Anna, any further?
So I think you've explained it beautifully. I think it's essentially it's controls the entry of new pharmacies into an area. So because we say our pharmaceutical needs are met, essentially that means there isn't the opportunity for new pharmacies to move in and have a contract. So ultimately we're producing this document for NHS England, who are responsible for pharmacy contracts as such. So if any applications are made to open a new pharmacy in our patch, they will refer to our PNA.
Portia, just before, I'm conscious we also just had Hitesh for maybe 10 more minutes. And this relates back to, I guess, all of you, is, and what I said before in terms of additional services, which I don't think are necessarily adequate in how they are perceived in this paper, and also the conversations we've just been having with Hitesh, what support at the moment are we sort of giving to pharmacies, and could we be exploring as a council to support them so that much of what we've been speaking about today might, I don't know, work better, but also we might be able to deliver more additional services across the borough, just to kind of loop that conversation up and include Hitesh that whilst he's still here.
Anybody else want to come in first, or I can sort of? Yeah. So in terms of the PNA, I think the PNA shows that there is adequate provision of pharmacies providing these services. So we don't need any more pharmacies to sort of be commissioned to provide any of the NHS services. I think there is adequate provision for all the services. So that I think is established in the PNA. But again, the previous discussion was around activity levels for certain services, but I think a lot of the other services mentioned in the PNA, are getting enough activity. So I think in terms of the PNA, there isn't any need of any more pharmacy services, or there isn't any gaps in pharmacy services provision. So any resident in any part of RBKC would be able to get any of the NHS pharmacy services quite easily. Does that answer the question?
So I will pop in and then I'll invite colleagues to join.
Yeah, I'm just going to quickly, if you can keep everyone's, I just conscious of the time too, and everyone's time too.
So we as a local authority also have the opportunity to commission services from our local pharmacies. And examples of that would be the stop smoking services that you've seen referred to in the papers. There are other opportunities that are wider than that we exploit as well. So, for example, around substance misuse services and opportunity to access things like needle exchange, and many pharmacists are involved in things like supervised consumption, etc. within that kind of pharmacy setting, or have been in the past. And there is also the opportunity for us to look at sexual health services via that pharmacy setting as well. And NHS health checks is something in the past that we've also looked at exploring and developing moving forward. We have got quite a strong relationship with the local integrated neighbourhood team. As you know, the integrated neighbourhood team are responsible for bringing together sort of a strategic approach to how services work in localities. Usman Khan, the Deputy Director of Public Health for RBKC, is now the co-chair of the West kind of INT group. So that's created opportunities for us, particularly to bring back some of the conversations we've been having with Hitesh to the integrated team to see what some of the opportunities are. And we've certainly had conversations with Hitesh about ensuring that we're having a regular meeting to explore those concerns. One of the things I'm quite keen on is to get more regular information in detail around pharmacies in our areas of deprivation. What are the opportunities for us to sort of develop more of a health promotion relationship with those pharmacies, particularly perhaps in the north of the borough and in the south of the borough. I'm really keen to explore with NHS colleagues what are the opportunities around maximising the pharmacy first offer in those pharmacies too, and building up quite a strong picture around that. So there's, as a result of kind of conversations we've had around this paper, there are definitely opportunities we've identified and conversations that we want to take forward.
I think you've covered it beautifully, to be honest. I mean, ultimately, the purpose of the PNA is the primary function is around, as you say, informing the market entry decision making by NHSE for NHS England for new pharmacies. But also we can use it as an evidence base to inform a lot of that decision making and how we want to sort of maximise use of community pharmacies in Kensington and Chelsea. So I think there's a sort of statutory requirement. There's a very functional element of it for NHS England, but it's also an opportunity for us, as Anna says, to have those discussions and to have those conversations, to see this as actually a really helpful evidence base for us in terms of what pharmaceutical services look like across the borough. And as we've noted, you know, we I guess the headline message is that we do have sufficient sort of pharmacy services, as I think we put it really well earlier. We have pharmacies providing enough those services across the borough. But it's about how we can perhaps sort of promote some of those services, promote awareness, and get the best use to really sort of maximise the health and well-being of our residents and reduce health inequality.
Thank you, Chair. I just wanted to talk about the public survey that 37 local residents and workers responded. Do you think that sample is robust enough to conclude that there's no gaps in access or quality?
So I can see that. So the survey, unfortunately, ended up being running for much shorter time than we would have liked to. The reason for that was because there was some back and forth with the ICT for them to accept the survey to be published without having any data protection issues that could arise. So the conversations took such a long time, but by the time the survey went out, it went on for a very short time. It was only up for about 2 weeks, which was not ideal. But in order not to delay the rest of the document, because it is a statutory document, so we need to make sure that it's out for consultation for at least 60 days. We chose to end not to extend the time that the survey was going to be open, and that's why we ended up getting 37 responses only. But the conclusions that are made are not just based on the survey residents; they're based on other analysis.
Okay.
Yeah. Sorry, can I just come to that? I think we did extend it, I think, for a week in the end. So I think it went for a few weeks. The issue, I think, the uptake wasn't great, and as you say, it's not. We recognise in the document that it isn't enough to make absolutely robust statements about the quality of some of the access. I think the thing to remember is exactly that. It's part of the picture. It's part of the. It's not ideal. We didn't get a huge uptake. we sort of promoted it through sort of residents' newsletters and comms, and put it on consultation engagement hub. What we'd like to do, and is also, we've done the same with the consultation. So the consultation is now open to the beginning of August. So there's 60-day consultation. And we'll be doing the same in terms of comms, and it's on the consultation engagement hub. So there's still an opportunity for residents to feed in, I suppose, is the message. So yes, it's, I think the previous time we did it, we had something like around 19 responses the last time, about 3 years ago. So it is definitely down from that. And it's certainly, not statistically significant in terms of numbers, but it is part of the broad picture.
My other question is, what steps will be taken to ensure future PCA engagement more meaningful with seldomly heard voices, groups, and vulnerable residents?
Yeah, so I think that certainly would be something that we'd like to promote, and welcoming input in terms of how we can promote the consultation phase as well, and make sure that we kind of get it out to communities. There is an opportunity, as I say, to feed in by, I think it's around the 8th of August, I think. So yeah, happy to have any suggestions around how we kind of sort of can promote it and make best use of existing comms channels. Yes.
I think you should take advantage for the summer season now. There's a lot of events going on. You should, be out and about, and the fairs and the street parties.
Yeah.
Sport and literature. Yeah, it's warm. Everyone is happy now.
I mean, it's yeah. I mean, I guess the consultation around the sort of P&A is obviously quite a structured consultation in terms of do people kind of agree with the sort of findings, around are there sufficient pharmacies? But we certainly had a survey that we used for that, and we could use that again.
I also think that you should, whenever someone goes to see their GP, first minute of their consultation or the last minute, that you could introduce them with a questionnaire.
Yeah, and certainly we promoted it through G. I think we promoted it through G.
Yeah, we did.
Didn't we? Yeah, we did. We did promote it through GPs previously, but yeah, we'd be definitely happy to do that again.
Thank you. I'll let one of my other colleagues talk about the deprivation, because I'm tired of talking about, diversity and, all that cultural competence, what we're going to do moving forward.
But in terms of
services being available to those in the deprived areas of North Kensington.
Sure, absolutely. I think, so what we've done in the kind of, for the purpose of the P&A, it has to look at, obviously we do a lot of mapping in terms of, pharmacy service provision by different areas. And obviously one of those we've done is around deprivation. I guess this is, as I say, where it's an evidence base to start those conversations about how we might want to see community pharmacies, what services we may want to see delivered, and what opportunities there might be to work with sort of local communities. Yeah.
I might add very quickly that we have been exploring opportunities to really strengthen those relationships, and one of the projects that we did with the NHS in the recent past is connecting our community champions up with our pharmacists. And we produced some videos which were all about encouraging local people to use the pharmacy, particularly in the winter season, when there's a lot of pressure on acute services and GPs particularly, and they were very successful. And we're quite interested in exploring ways to keep that marriage between the community champions and the pharmacists as we move forward. And when I was speaking to Hitesh earlier on today, one of the things we discussed as well, many folks who work in pharmacies are local residents and representative of local communities. So that creates an opportunity as well. to bring messages out into the community and to encourage people to come into pharmacies. And we were going to explore again how we could link that up with community champions, and particularly around immunisations and screening. And as you know, some pharmacies are now offering immunisations, and particularly MMR immunisations has been a recent development within pharmacies, and we're really keen to encourage and promote pharmacies to offer immunisations as a part of broader offer to our community.
Yeah.
Just a quick question. It's quite a sort of specialist document. With the consultation, I know it's only just open, but I was just wondering whether you'd had any responses already, and what sorts of responses you might expect from this consultation, and how many of them.
So, from experience in the past, we don't get a huge number. So the consultation, there's a prescribed list of stakeholders that you have to send it to. And to be honest, that is the scope of the legal requirement for the consultation. So you have to send it to the LPC, the local medical council, all the GPs and pharmacies, NHS trusts, neighbouring health and wellbeing boards, NHS England. And the majority of responses that we tend to get are from either from pharmacies, I think we've had a few from pharmacies in the past, NHS England will submit a response because it's essentially a tool that they want to be using. It's for them. They usually respond on the last day of the consultation. And we will get feedback occasionally from neighbouring health and wellbeing boards. So obviously, particularly if there's sort of around because as part of the P&A, you'll see in the mapping, we consider obviously pharmacies in Kensington and Chelsea, but also around the outside because people, don't just go to pharmacies just in their borough. So, we sometimes get responses from them. That tends to be it. I mean, sometimes NHS trusts come back, but by and large, we do get some public responses, but not a huge number.
Yeah. So the responses, as Colin said, they're usually very low. It's because it's a very technical document. NHS almost always responds on the last day, and majority of responses are around changes that have occurred, particularly with times like opening times would have shifted since the document was drafted.
Do you think you'll get anything about Pharmacy First or anything like that?
Actually, in relation to questions, I don't think we've had any responses yet. That's not, to be honest, that's not a surprise. They do tend to be later on. It'll be interesting to see. Yeah, we've not generally had too much commentary in previous ones on like you say, a specific service like that. But yeah, it'll be interesting to see.
I'd said another point too, which was just on the 100-hour sites, which obviously one of which was Tesco's, that's closing, and just sort of whether the P&A should reflect that.
You're going to get the one back on Sloane Street now, which I know is not accessible for everyone. Especially those in the North Borough, which Portia referred to about, more vulnerable people, and they're not going to travel down to Sloane Street because it's not. So I'm not sure what we can do.
Yeah, I mean, the 100-hour pharmacy, I mean, as you say, we'll obviously be losing one. I think as Hitesh sort of stressed earlier, actually, they're not necessarily 100 hours these days. They have, and I think this is a national trend we're seeing of sort of closures of 100-hour pharmacies. I think it's important to remember that it's a kind of contracting arrangement. So you have 40-hour contracts or 100-hour contracts. A lot of the 40-hour, although given the financial pressures, obviously it's just flagged. So pharmacies on a 40-hour contract are able to sort of open later and can add sort of supplementary hours. So I think in terms of the specific around Tesco, I think as kind of has been said, it's flagged in the P&A. It is acknowledged that obviously we'll be closing. It had a very low dispensing numbers per month. I think it is about 2,000 and something a month. There are 4 pharmacies within a 10-minute sort of walk of all of those. Now, I appreciate that that the opening hours may not be as accessible, and obviously it's perhaps there is definitely some of that convenience factor that will have been there from obviously in the supermarket. But we don't see it as significantly affecting sort of access to services in that way.
And there are of course sections on the evening and the Saturday opening.
Yeah.
To what extent that's 100 hours.
And then my other question was just on access, how we're measuring access, if we're kind of considering patients who might be disabled or have complex needs. So just.
Yeah, the standard that we took is a kind of 1 mile for sort of 20-minute sort of access, either by walking or public transport, and that's the sort of standard that's come from sort of previous reports as well. And I think it was mentioned in the Darcy report last year in terms of access to pharmacies, which is kind of what we based it in on. Acknowledge obviously that some people will have more difficulty getting to pharmacies. I think obviously for people perhaps who are sort of maybe housebound and not so able to get out, there is potentially the option for deliveries, although that's not actually within the scope of the P&A, because then it's a local sort of financial decision for a pharmacist to whether to offer that as a service. So in terms of it's a kind of standard that is generally used that we have followed in terms of access, but obviously recognising that, I mean, I know obviously a lot of people will maybe sort of, I think the survey maybe showed that a number of people would be picking up prescriptions for all other people and so, but yeah.
Yes.
Just one question, and hopefully it's not too broad. Just thinking about the context of all the different strategies that the council's already committed to. So the 10 years health and wellbeing, is that? Yeah, the health and wellbeing strategy and the wearable health and wellbeing. I'm sure that's mainly NHS. Looking at what needs to be implemented through those strategies, were there any gaps in the resources from this exercise that were identified at all that need flagging? And is thoughts about how those gaps might be addressed? Just thinking about the stuff that the council's already committed to.
Yeah, I mean it's obviously there's strategic context is vital. There's not any, I think, in terms of the scope of the P&A, it's definitely important. I mean, essentially what we're saying is that there is sufficient pharmacy services across the patch, and I should say for the license of the P&A for the next 3 years. And just as a slight another note, if there are significant changes within that 3-year period, we've projected changes in terms of demographics and housing developments and so on. But if there is something unexpected and there is a change, there is a requirement for the Health and Wellbeing Board to publish a supplementary statement as well. So it's not that we have to wait 3 years for another P&A. We can also publish a supplementary statement if there is a significant change. So I just wanted to address, because I think that is quite important. But in terms of the strategic context, we obviously have to acknowledge that context, but it's not necessarily the role of the P&A to sort of look at how we sort of make sure we sort of addressing gaps in other areas.
No, absolutely. I guess I'm just thinking about the needs assessment that was carried out for this exercise and whether it flagged any concerns about an ability to meet commitments that were made in the strategies. But
no, it's not. Yeah, it's not generally within scope of the P&A. I mean, basically, what we're saying is that we have sufficient pharmacy services in place to meet the local needs. Yeah.
Without needing to kind of think about them.
Yeah, and of course there isn't. Yeah. It is focused very much on the sort of services the pharmacies can provide, acknowledging that there is a wider context, obviously, because people will go to GPs and there are there's a broader health and
that might
sort of
well be
context.
you to ask that question.
Thank you very much. I think I'm going to but I think it would be great if the committee could receive the feedback.
Yeah, sure. Yeah, absolutely. And as I say, please, I'd like to invite the committee to sort of feed in as well.
Absolutely. I think Portia's given me some recommendations on
Yeah.
how you get about
Yeah.
stuff like that. But thank you very much, everyone.
Thank you.
For this report. Moving on to agenda item 7, which is the work programme report. This report sets out the development of select committee's work programme, identifying priorities for municipal.
Agreed.
Select committee members are recommended to confirm the scrutiny priorities, which are in Appendix 1. Quite important, which will be presented to the Review Scrutiny Committee on the 15th July 2025. Agreed to develop detailed work programme setting out reports and items to schedule meetings of the Select Committee during 2026. Note that rescheduling of the 18th of September meeting will need to be considered to allow scrutiny of safeguarding adult executive board planning.
Probably that we move.
Everyone had a say. November.
Yeah.
So if everyone's had a look at
So
those
2 in November.
topics.
Would
We
make
may want at the start or the very end of November.
Yeah.
If we can't do the end of October, which is half sure that might be
Yeah.
doable. We'll consult the lead member and officers and
Yeah.
the committee to find a date.
Can we consult with the committee?
Yeah,
I think
sure.
that's
Yeah.
doing
Yeah, it's constant.
And just if everyone agrees over those topics and agreed, great. This concludes the meeting. Thank you to everyone for attending the meeting.
Thank you, Chair.
Thank you.
Thank you, Madam Chairman.
Just about one more.
It's very obvious, right?
I will.
Yeah. Well, that's first, and I, they don't know.
Before.
You know, all those.